All right. Assalamu alaikum wa rahmatullah. Good afternoon, everyone. Thank you for the introduction, and I would like to thank the SSBMT Scientific Committee for the invitation to present our local experience in graft-versus-host disease. As we know, bone marrow transplant cure majority of patients with hematological malignancies and non-malignant hematological disorders. However, this is procedure is associated with a significant risk of transplant-related mortality. Graft-versus-host disease is a complication of bone marrow transplant that is associated with a significant portion of this transplant-related mortality. Acute GVHD, as we know, characterized by involvement of the skin, gut, and liver with inflammatory process. That is mainly derived through the donor T cells. And chronic GVHD is another different complication from the acute GVHD with its own characteristics and pathobiology. We know this complication associated with a significant amount of transplant-related mortality. T cell mediated injury is the main cause behind the acute GVHD pathobiology. However, chronic graft-versus-host disease differ in terms of pathobiology, in terms of the contributors of innate immune system and adaptive immune system. Recent registry-based data from EBMT megafile showed that there is actually a decrease in the incidence of graft-versus-host disease over the past decades, with the recent data showing that incidence of grade 2 to 4 acute GVHD is around 28%, and this has been also associated with a reduction in the non-relapse mortality as well. And I think this is highly contributed due to the improvement in the conditioning regimen and the novel prophylactic modality that's been pioneered. Chronic GVHD as well, in a recent data from CEPMT are showing that there is still an increased risk of developing this kind of complication. So, over the past years, there has been an increase in the transplant centers in Kingdom of Saudi Arabia, and this has been increased in the bed capacities, and this has led to increase the rate of bone marrow transplantation offered for patients within the kingdom. However, there aren't any a lot of data about the complications associated with this type of transplant, including data related to graft-versus-host disease. So our aim is to share with you the incidence of graft-versus-host disease within our institution, and also will shed a light of treatment pattern and clinical outcomes within our institution. We include patients age above 14 and who underwent allogenic transplant. Of course, we exclude patients with the sickle cell disease because we've done a lot of them, but those patients, they receive actually non-myeloablative conditioning regimen composed of Cambath, TBI, and sirolimus, but this has been associated with very low risk of acute GVHD and chronic graft-versus-host disease, and this data has been published multiple times. The data has been collected between 2016 and April 2024. In April 2024, acute GVHD grading, we use the MAGIC criteria, and the NIH grading, we use the chronic GVHD organ scoring, and I did all the descriptive analysis so far for our data. So we identified a total of 264 patients underwent allogenic stem cell transplant. 57 of them are male, with a median age of 27, ranging between 14 and 69. With the most common diagnosis as acute leukemias, including AML and ALL, of course. The second most common indication for allogenic transplant was bone marrow failure. That includes severe aplastic anemia and inherited bone marrow disorders. Hemoglobinopathies is also included in this analysis because those are patients who were treated outside the Cambath TBI platform. We use the Haplo platform, which consists of flow cytoTBI, Thyrotiba, and ATG and BT-SI as well. So we included around 31 patients here with a different indication, including sickle disease and fetal thalassemia. Lymphoid malignancies, including non-Hodgkin lymphoma and Hodgkin lymphoma, is around considered around 9%. So most of the patients, they have a good comorbidity score, and they have also good performance status. Around 50% of our patients receive myeloablative condition, because you can see the high proportion of patients, they are actually non-leukemia, they are bone marrow failures or they are hemoglobinopathies. So majority of our patients, they receive, 50% of our patients receive myeloablative, but we have a good number of reduced intensity condition here, and as well as non-myeloablative. Of course, we have high rate of match-related donor transplants, so around 66% of patients, they are actually match-related donor, followed by haplotransplant, haploidentical, and followed by match related from the donor registry. The most common graft source was peripheral blood, around 83%. We've used the TBI in 43% of patients, and we've used an ATG in 44% of patients. Primarily the ATG, we use it in the MUD setting as well as in the hemoglobinopathy setting. BT-SI is used in 22% of patients, and this is primarily for haplotransplant. We are slowly adapting the use of BT-SI in match set and in MUD setting, but we're not there yet. The most common prophylaxis used, which is the CNI plus methotrexate, followed by CNI and MMF. And sirolimus MMF mainly for the hemoglobinopathies. So in total, we have an overall rate of grade 2 to 4 acute GVHD of 22%, divided between the most common is grade 2, 48% of the 58 patients identified, followed by grade 3 and grade 4, with a cumulative incidence of around 22%. The organ involvement, actually, as you can see here, the most common is lower gut and skin, followed by upper and liver. And the median time of onset was around 6 weeks. I did just a quick separation for the curve here. There was actually no difference between, although it looks like there is a higher rate in the myeloablative and reduced intensity, but still it's not statistically significant when compared to the non-myeloablative. Looking into the responses, so day 7 response to the first line systemic therapy, which is steroid, was around 65% overall response rate, 10% only CR, and 55% partial response. There were 31% progressive disease, and 33% of the patients actually went on to receive second line of acute GVHD. The most common second line was actually ruxolitinib, followed by ECP and anti-cytokine, which has anti-etanercept and others, including ATG. So overall, the response rate at day 28 for all patients, all comer, including those who are refractory and all patients diagnosed with GVHD, the overall response rate at day 28 was 73%, with a 50% of them they are in CR, and 22 are in partial remission, 26 in progressive disease. And the best response was actually overall 84%, and finally 80% of patients achieve CR with different lines of therapy. And the median time to this response was actually 5 weeks. In terms of the outcome from the acute GVHD onset, we had around 47% cumulative incidence of death for patients after acute GVHD onset, and there were 9 deaths probably related to progressive acute GVHD. They actually died while on complete remission, and the relapse rate after acute GVHD was also another 9%. Okay, so now I will review the chronic GVHD data. So we have a rate of around 34% of chronic GVHD identified. 88 patients in total. 50% of them they are moderate, mild was 23%, and severe with 27%. Organ involvement, 30% they have only one organ involvement, 47% they have 2 to 3 organs, and 23% they have 4 or more organs. The most common organ involved was skin, followed by mouth, eyes, liver at 37%. Lungs, we have we identified like 20 patients with lung GVHD, and they constitute around 22% of our patients. Fascia and joint was the least at 10%. In terms of responses for chronic, systemic steroid was actually initiated in 88% of patients at one point. And the response at 1 month from the initiation of steroid, as you can see, 16% achieve CR, while 39% they achieve partial remission, and 43% they have form of progressive disease. Second line was initiated in 57% of patients, and ruxolitinib was the most common second line, followed by imatinib and ECB and then protinib. And ECB was actually used in third or beyond line, but it has been used here as a second line in for patients. So responses in general for all comers from the onset of the GVHD, 60% they were able to achieve CR, and 23% they have stable disease, 6% they have PR, and 10% unfortunately they still have progressive disease. And with a median follow-up of 28 months for the whole cohort, the overall survival of patient was around 60%, and the care for graft-versus disease-free, relapse-free survival, this was actually acute graft-versus, it wasn't including the chronic, but as you can see here, it's reaching around 40% at 3 years. In the end, I would like really to thank our team and for the massive job that they have done for the improvement of our program and the establishment of clear policy and guidelines to treat chronic GVHD patients, improvement in data management and collection system for our GVHD patients, and special thank really to Ms. Inam Shahabuddin. She did a massive job really for the improvement of the program, as well as to collect this data for me. Ms. Shahabuddin, actually, we are missing her really a lot. She's leading the program, and we wish her all the success in her future career. Thank you very much, and